Hello KJR readers. It is a great honor to introduce our study results in Listen to Author section. I am Hyun Kim from Seoul National University Hospital. The title of our research is Contrast Enhanced CT and Ultrasonography Features of Intracholecystic Papillary Neoplasm with or without associated invasive carcinoma. First, I briefly review the introduction and purpose of our study. According to the 2019 WHO classification, Intracholecystic Papillary Neoplasm (ICPN) is a grossly visible, mass-forming, non-invasive epithelial neoplasm arising in the mucosa and projecting into the lumen of the gallbladder. ICPN encompasses previously used terms such as papillomatosis, papillary adenoma, tubular papillary adenoma, and intracystic papillary neoplasm. It is similar in concept to IPMN of the pancreas. According to the previous pathology report, more than 95% of ICPNs have high-grade dysplasia. In addition, over 50% of ICPNs showed invasive carcinoma component at the time of diagnosis. So, preoperative diagnosis of ICPN and prediction of ICPN with associated invasive carcinoma by using CT or ultrasound are quite important for determining patient treatment policy. Therefore, the purpose of our study is to assess the contrast-enhanced CT and US findings of ICPN and determine the imaging features predicting ICPN-IC. This is a retrospective single-center study. We enrolled 119 patients with pathologically confirmed ICPN who underwent preoperative CT or ultrasound. The pathologic diagnosis of ICPN was based on the 2019 WHO classification. CT examination was performed using various CT scanners. Ultrasonography examination was also performed using several commercially available US units. For image analysis, two experienced radiologists retrospectively reviewed CT and US images. They evaluated gallbladder wall and polypoid lesion characteristics in abdominal CT and US. We performed univariable and multivariable analysis to identify significant predictors for ICP-NIC. And for comparison of diagnostic performance to discriminate ICP-NIC from ICP-NDP, we calculated AURC. Turn to the result. Invasive carcinoma was observed in 42% of the patients with ICP-N. Patients with ICP-NIC were significantly older than patients with ICP-NDP. Schematic drawings with representative images of CT and ultrasonography show three imaging patterns of ICP-N. Type A represents gallbladder wall thickening with polypoid lesions. Type B lesion shows gallbladder wall thickening without polypoid lesion. Type C means that polypoid lesions without wall thickening. According to this classification, there were 49 patients with type A, 6 patients with type B, and 60 patients with type C. The remaining 4 patients showed no abnormal wall thickening or polypoid lesions on preoperative CT or ultrasound. In multivariable analysis, maximum wall thickness and mucosal discontinuity were significant CT image features for predicting ICP-NIC. Regarding ultrasonography variables, the maximum wall thickness of ICP-NIC was significantly thicker than that of ICP-NDP. However, there was no significant US feature for predicting ICP-NIC in multivariable analysis. This is a representative case of ICP-NIC. Contrast-enhanced CT image shows diffuse wall thickening of the gallbladder with mucosal discontinuity annotated by arrows. Pathologic specimen shows numerous diffuse papillary lesions along the gallbladder wall. In terms of polypoid lesion characteristics, Multiplicity of polypoid lesion and the presence of tumor base or thickening were significant predictive CT imaging features of ICP and IC. Among US variables, only lesion size was a significant predictor of ICP and IC. This is a representative case of ICP and IC with multiple polypoid lesions. You can see multiple polypoid lesions and tumor base were thickening at CT scan. In ultrasonography examination, the largest lesion was 3.3 cm. Pathologic specimen shows multiple papillary lesions in the gallbladder body. In terms of AUROC, CT showed significantly better performance than ultrasound for discriminating ICP and IC from ICP and DP. In conclusion, ICPN showed polypoid lesions and/or were thickening on CT or ultrasound. A thick gallbladder wall, multiplicity, presence of polypoid lesion base or thickening, and large polyp size could represent useful findings to differentiate ICP and IC from ICP and DP. Thank you for your attention.